All right, so it is my pleasure to introduce Karen Smith. Dr. Karen Smith was sworn in as the Director of the California Department of Public Health and State Public Health Officer on March 23, 2015. Dr. Smith is a physician specializing in infectious disease and public health. Prior to her appointment, she served as Public Health Officer and Deputy Director at the Napa County Health and Human Services Agency from 2004. Prior to moving to Napa County, Dr. Smith was a TB Control Officer for Santa Clara County. During her 8 years as TB Controller, Dr. Smith served on the CTCA Executive Committee for 5 years, including serving as President from 2003 to 2004. Dr. Smith was awarded the CTCA Henry A. Rentelen Award in 2015. So please welcome Dr. Smith to give our Jane Ash Memorial Keynote Address.
Thank you.
And welcome back.
Okay. Good morning, everybody. This has been already such an amazing morning for me because it's Old Home Week. 20 years ago, I was doing exclusively TB and maybe a little bit of bioterrorism just for fun. But so seeing so many of you, again, is really, it's fantastic. I can't tell you. And also, Jane Ash was a friend of mine, so being able to come and do this lecture is pretty cool. That said, this is one of those lectures where I'm actually talking to an audience that already knows everything I'm going to say. So for those of you who are really comfortable with equity, disparities, all those terms, et cetera, and how they apply in tuberculosis, get yourself another cup of coffee, restrooms down that way, find your friends, chat, not in here. But seriously, though, I thought hard about what would be of value. And so we, I think most of you know, or some of you know, we have an Office of Health Equity in the Department of Public Health. And that was an intentional thing, rather than having an Office of Minority Health, Office of Women's Health, et cetera. Excuse me. When it came time to do some consolidation, it was very intentional on the part of the Governor's Office, the Health and Human Services Agency, and the department to refocus all of that work into the concept of achieving health equity. And so what I'm going to do is essentially just share with you first some terms, okay? And I'm going to leave all the data to Pennon, Dr. Barry, who's coming up later, who does it really far better than I do. But I'm going to give you some really difficult to understand terminology. So if you look at the graph, if you look at the graph up there, that gap between the high line and the low line, that's a disparity, okay? Everybody's clear. We can move on. You can't see it yet. Oh, I'm sorry. It's not. Can you guys, sorry. It's my bad. Sorry. There are 3 things I have to do all at the same time, and, I'm really limited to 2 on a good day. All right, there we go. Line on the top, line on the bottom, gap in between. Health disparity. Okay, these are your classic TB graphs. Everybody should recognize this. Many of you have taught with these slides, you've discussed these slides, et cetera. So, but what we're talking about here when we talk about a disparity is the difference in a number between one group of people and another group of people with respect to a health outcome or a health condition. And it is nothing more than that. In fact, not all disparities are inequitable. So the term disparity and the term equity are not the same. They're used interchangeably, but I would caution you to be careful about that because they really have different meanings. Numbers are pretty much, they can be used in the wrong way, but a number is just a number. And not all, as it says here, disparities are inequitable. An example would be the difference in lifespan between women and men. That's one example. It's large, or the rate of sickle cell anemia in African Americans versus whites. These are factors not having to do with equity. And to move on to that, where disparities reflect a difference in a health outcome that sorry, I'm trying to figure out. He's running. Never mind. This is challenging for my very slow brain. All right, here we go. I want to be sure I'm talking about the right thing here. with what you're seeing. Okay, so when a disparity in health, those numbers, those differences between two groups of people reflects something that is avoidable, and usually it reflects something that is avoidable by a decision that a society or a community makes. Now we're talking about inequity. If the decisions that your community makes favors health outcomes for one group of individuals over another group of individuals, we're talking about a social inequity, okay? And those social inequities are what lead to health inequities. So that was the difference between disparity and equity, okay? Questions? Good. Okay, so let's move on to the next really complicated concept. And by the way, I love that you have the baseball game image of the difference between equality and equity, which is what I'm going to talk about right now. But I've chosen this more politically correct. So you'll notice that the people in the looking at the baseball game thing have just a little bit more male than female. So and so here, and they're sort of observers rather than participants. So here we're doing the public healthy thing. We're all going after an apple. Okay? And determinedly gender-neutral icons for people. Trying to, do the right thing here. So this is equality. This is when everybody gets the same thing, the box being the thing that we give people. And this is the term that the average citizen uses all the time. We should all be equal. Well, we're not all equal. So we should all get the same thing. How come some people should get more than other people? That's just not right. We should all get the same thing. But the truth is that, okay, oh, sorry, I keep forgetting it's the left hand that has to do that. To get us all to the same place, we need different things. You can't giving everyone the same does not create an equitable society. What we need to give people, and by the way, I would point you to the Constitution of the United States, a frequently misquoted and poorly used document these days, says an equal opportunity. And that's what we're striving to achieve, frankly, in our world of health equity. We want to give people in communities an equal opportunity to achieve their optimum health. Not everybody is going to achieve the same level of health based on things other than society. What we're working to do is to make all of us, and that we as everybody here in this room, is to make it possible for people to be as healthy as they can be. Give them the opportunities to do that. Okay. So now we're going to talk about the determinants of health. Anybody here unfamiliar with the determinants of health? It's actually kind of important to have this, so I'm going to walk through it. There are a few people in the audience, I think, who haven't seen this, but I'm going to do this from the public health perspective. So at the top of the screen, you see mortality and morbidity. Those are the things we are attempting to not have. Just so you know, not mortality, we all have to have that. That's going to happen. But to keep it to where it ought to be and when it ought to be, as opposed to excess mortality or morbidity, which is sickness versus death. And those are what we call health outcomes. Those are the ultimate health outcomes. We measure a lot of other things, but just to be sort of simple in our thinking here, that's the goal. That's why it's at the top. Those are the things that we're working on. Now, did it go? Yeah. So the things that determine your health outcomes are health factors of a wide variety of types. The most common one that we talk about in this country is access to care. So the entire conversation about health care and health, and including public health, is if we just give everybody health insurance, everyone will be equal, and we'll all sing kumbaya into a very healthy future, golden years, blah, blah. However, what we know is even if you give people health insurance, that doesn't mean they have access to care. I'm preaching to the choir, as I said I would. But even more interestingly, even if you give everyone health insurance and access to high-quality care, that's the third piece of that, you're really only accounting for about 10 to 20% of those health outcomes at the top. Yet that's the conversation we've been having for 50 years in this country. That's the focus that we've been having, and that's, quite frankly, the thing we're fighting over right now. For those of you who aren't aware, the Republicans have released their draft bill. So that's 10 to 20%. So even, however that conversation in Washington pans out about repeal and replace, it is not the whole story. We still have a whole lot of work to do. So what else is there? Well, when we do talk about anything other than healthcare, what do we talk about? Anybody? Behavior, right? Personal responsibility, risk behaviors. And those things like tobacco use, sorry, I can't quite see it up there, diet and exercise, or lack thereof, like the diet I had this morning before I came. Those things are, we believe, or have been taught, are basically personally determined. It's my choice. It's my choice whether I smoke. It's your choice when people are into blame that you're fat, or that you're sedentary, or that you're this, or that you're that. But what we know is that the choices that people make are actually constrained by their circumstances. Now, that seems like it should be a giant duh. But I encourage you to listen to those conversations when they occur and be aware of just how much that we rely on that mythology in America. There are basic myths that lie at the heart of every society on the planet. Some of ours in America are the enemy at the gates. Okay, enough said about that. Think about who the enemy at the gates is currently in the political dialogue. But also, it's the pull yourself up by your bootstraps. That's shorthand for you determine what happens to you. Or, more commonly, it's your fault. So, but even if you look at these risk factors, these behavioral risk factors, and you add them in, they're only 30 to 40% of the determinants of health. So what are we up to now if we're really generous? We're up to 60%. That's the entire conversation that was happening until about 10 years ago, even in the world of public health. So where's the other 40%? Well, that's what we're here to talk about today. These are the things that you don't personally have control over, even if we pretend that you have total control over those risk behaviors, which all of us who work in this world know isn't the case. And those are social and economic factors and, to a lesser extent, the physical environment. Those are I call them the societal determinants of health, the social determinants of health, whatever term you want to use. It's actually a really annoying term. I encourage you not to use it with people outside the world of public health because it annoys them and they don't know what it means. And it's easier to just say the things that, as Andrew Deckert, a longtime health officer in Shasta, once said over a conference call, he said, when I try to explain it, I said, if I decide to ride my bike to work every day, that's my decision. That's, I can take pride in that. That's something I have control over. But if I get hit by a car 3 times in 1 year because there's no bike lane, that's not something I have control over. And I think that's one of the clearest examples of the difference between the behaviors that as you choose and the ones that society creates for all of us, and that we have to determine our behaviors based in that milieu. So this is where we need to be, this is how we need to think overall about the policies and the programs, which is at the bottom of the slide, that we are promulgating in the world of public health. And the actual practice that we're taking into account. And the reason I say I'm preaching to the choir is because I know a lot about how TB control programs work. And what you do every single solitary day is address those societal determinants of health for the people that you are touching that have tuberculosis and those who may have been exposed to tuberculosis. And that is the most important thing that we do. Yes, the clinical care is important. It really is. But that clinical care and getting people through care doesn't work if we don't address the context in which that human being is existing and trying to treat their TB, which I think is worth saying, even to all of you who know it all so well already. It's also something, by the way, that I use a lot when I talk about why we need to continue to fund tuberculosis control programs, even when the rate is dropping, which, by the way, it isn't in California, and Penn will explain that to you. nonetheless, we really do have to use what we know about what we do and use it in English, not social determinants of health language, when we tell people why it matters that you don't just because somebody has Kaiser health insurance and can go to a Kaiser office and get a doctor and get a referral to an ID doc. That's kind of like our idea of the perfect world, not Kaiser, just that ability to be in a network of healthcare providers who know what they're doing, speak your language. Oh, wait, now we've sort of moved into the social determinants of health thing again. But what you do when you're out there, those of you who are case managers and others who are helping people to get through their therapy, that's really where the money is, and that's the thing that we don't value. Not us in the room, but us as a society. And changing that narrative when we talk to decision makers, policy makers, elected officials, whether it's in your city, your county, or at the state, is incredibly important if we really want to achieve equity for people with tuberculosis. So, I keep forgetting to do the one that actually changes your slides. I know where I am because it's right here. I don't know where you are. Okay, so, oops, sorry, go back. There we go. So this is what I said before. I said much more better by someone else. I can't remember who this quote is from, and I apologize for that. But people's behavior is shaped by the real life choices and opportunities available to them. Oh, it's Tony Eaton. Sorry, I should have known. Where they live, work, learn, and play. And that is actually at the heart of understanding what people can control and what they can't control. And I used to get really frustrated, especially early on when I would see TB patients and they would come into the clinic and their compliance had been less than ideal, or they were still drinking, or whatever else, was making it a challenge for them to get where we thought they should be. It was always important to remember, and I've said this before when I teach, that their tuberculosis may be the single most important thing about them to me, but to them, especially when they're feeling well and able to go back to work, it's feeding their kids, making sure that they're housed. It's so many other things that are their priorities. So I always thought that more than being a doctor, my role for them was to help them prioritize their tuberculosis in the context that they lived in. And honestly, that's not just true for TB. That's true for every other disease, particularly chronic diseases like diabetes, et cetera. If only we could get the healthcare system to really recognize, and we're moving in that direction to give people full credit, that they have to address their patient in the context in which that person lives and not just in the context of your medical relationship with that patient. That's a lot to ask in the typical 15-minute appointment, which says a little something about the way we organize our healthcare. Okay. I want you to hear about this from your colleagues, so I thought it would be fun to play this little video. Can you hear it?
So the biggest health problem we're facing today in this country is inequity.
They are rooted in those determinants of health and those social inequities.
Health is determined by where you live, where you play, better employment opportunities,
quality education,
access to housing.
The forces that created essentially disinvested communities.
Truly not fair, they're not equitable.
No one should see their kids get sick more frequently because of injustice.
Social injustice.
Equity means that we have a stool or bench for those who need it so they can see over the fence.
All people, regardless of where they live, how much money they make, the color of their skin,
has the same chance of being healthy,
having an equal shot at a happy life,
being able to have equal access to health services, breaking down some of these inherent barriers.
People being able to take advantage of that opportunity to meet their potential.
And it's difficult to try to go upstream and get to, some of the underlying root causes. It's going to require new partnerships and new ways of practicing.
The public health officer is the connector to bring people together to solve a problem.
Collectively, we have strength.
We must work in partnership.
That's what's going to change health outcomes.
So you could break each of my fingers off really easy, but when I bring them together, you have to pry them apart to break them.
Absolutely the new way of thinking about
the optimal well-being and health for all Californians.
We are creating the next generation of public health leaders.
The Health Equity Award is really designed to acknowledge those health departments that are really taking great strides.
And really inspire others so others can really see what's possible.
To steal shamelessly from each other and share seamlessly.
There are a lot of really hard-working public health professionals who are leaving a legacy. Those people are quite heroic. California is leading the way into the 21st century.
Next slide, please. Oh, wait, that's me. Never mind. Okay. So I thought it would be fun for you to see. Anybody see some familiar faces in that group? Yeah? Yeah. I have to out myself at this moment. Lisa Pascapella, who's sitting here in the audience, when I worked in the TB branch, before there was electricity, we were sitting around the candles talking about how we make our case for the TB control program. And Lisa was talking passionately about social justice. And I was sitting there going, oh, God, as soon as you say that, they're all going to hate us. They're going to turn away. We're going to be called communists. And, well, it's like, could we not use that term? It's such an inflammatory term. Well, I'm here to tell you, in my new lofty role, which ain't so lofty, but I use the term social justice all the time because ultimately that's what health equity is about. I rapidly transition to health equity from social justice, but I use the term because it's really pertinent. That is what this is about. It's about being fair, and I have a huge thing about fairness. And we are not fair to people with diseases like tuberculosis. And just to kind of a shout out to my colleagues, some of whom are in the audience from the California Conference of Local Health Officers, this is the definition of health equity that they adopted about 18 months or so ago. The assurance of conditions for optimal health and well-being for all people and communities for both present and future generations. So you can see why I say social justice. It's like easier. But the bureaucratic language, this kind of formal definition is also really important because it defines what groups of people stand for and what groups of people mean when they say health equity. All right, so enough of the language lesson. Let us move on. So a story or two just to kind of think through a little bit how this plays out in real life. Think about patients you may have seen. So this is a college student. These are based on true stories, but they're not. I've changed the details pretty significantly to protect privacy and also because it helps me make my points. Nobody's case is perfect for what you want to say, nor should it be. So this is a student in a small California technical university who was diagnosed with smear-positive tuberculosis. His insurance, he did have insurance, but his insurance didn't cover his workup, his x-rays, and he was left with very large deductibles and copays. For a student, it's very little money. He's independent of his family. So his choice was continue school, pay the rent, or get treated for his tuberculosis. So you can see where he was my patient, his tuberculosis was my main thing for him, but that's not his problem right now, especially as he began to feel better. His school, to make matters more complicated, has no medical professional on the faculty, on the staff at all, no clinical resources for students or those exposed to this young man. He lives because he has so little money in a very crowded apartment with multiple other students. So let's think for a second, what are some of the challenges that this young man is facing in terms of determinants of health? So we can get the whole he does not have access to high quality, affordable health care, both because he does have health insurance. That should make it all okay, right? But it doesn't. The copays are beyond his financial means. What's more, there is no medical provider where he is. The closest medical providers are quite a distance away, and it actually takes transportation resources to get to those providers. And where this technical college is. He also, those providers are primary care providers, and they're primary care providers who live in a part of California that doesn't see TB very often. And so their knowledge of, their clinical knowledge of how to treat TB is limited. So the access to high quality, affordable health care is a huge determinant of health for him. But what about those social determinants? So he lives in a fairly rural area, and he doesn't have his income. So does anyone know what are the 3 most powerful social determinants of health? Anyone want to shout one out? I know we're going to freak out the people who are recording things, but feel free to shout something out. Educational attainment, that's one of the 3. Social support? That's a little she said social support, that's a little too aggregate. Employment, housing. What are all those things determined by? Income. Income, okay? Educational attainment, income, and the third? Racism. Race and racism. Those are the 3. And this young man, who is Latino and an immigrant, poor, or relatively poor, poor is a relative, but for what his needs are to take care of his TB, he has high educational attainment. He's trying very hard to get higher. So this is the reality of and he is one of our patients who actually has more resources than many and is poised to really make it, to take that next step that will allow him and his future children to have a much better life. Because remember, poverty is a generational issue. It isn't just yours. It can roll down the generations and has in our society. Okay, so that's our first case. Don't worry, I'm not going to do many of these, but let's talk about his friends. So again, the school, these are individuals who live in close contact to this young man, and they live in the same household, spend a lot of time together. They're also friends. They like each other. They study together. They actually study together with other people in the library, in small rooms, etc. So these young people also have a risk for tuberculosis because of their exposure to the smear-positive case we just talked about. They are in the same circumstances that he is. Not necessarily all are Latino or immigrants. Some are born in the U.S., white, but they don't have a lot of money. They don't have good transportation options. There is no medical professional near where they are trying to go to school who understands how to treat TB. So even though you're white and in college, so you obviously had some resources, it doesn't make it necessarily easy or even possible for you to complete your TB treatment without some assistance. Okay, our second case, oops, I'm sorry, I'm forgetting to do the one that's supposed to move on. Those were his friends. Okay, now we're to the second case. This is an 8-month-old Latina from a family in low socioeconomic status. Isn't that a nice bureaucratic term? They're poor. They're poor. And they've had issues with drug use in the family. The child's not been in primary care, and she developed 2 weeks of fever and irritability before they were able to get her to see a doctor. And the doctor that they went to was an emergency department. She was started on antibiotics, but the fever persisted. She stopped eating. She wasn't taking much fluid in. She had increased fussiness, vomiting, and diarrhea. They took her back to the emergency department. The emergency department, after the second visit, referred her to a pediatrician. Before she went to the pediatrician, she made another trip back to the emergency department because it was getting worse. Made it to the pediatrician. Pediatrician gave her some other antibiotics and sent her home. And she came back to the emergency department a 4th time. I think I've got the order wrong because there was a second pediatrician visit, 3rd round of antibiotics. Has anybody seen patients like that? Okay. So at the second emergency department visit, at the 4th emergency department visits with 2 pediatric visits in between time, she had seizures and was finally admitted to the hospital. She was transferred to a regional hospital very soon after, admitted to the PICU, and for the clinicians in the room, I have to give you a little bit of stuff. So hydrocephalus, edema, possible infarct. She was intubated. Turned out that this child had tuberculosis, meningitis, mastoiditis, which was diagnosed 4 weeks after her initial symptoms, and 2 weeks after her first emergency department visit, and 2 days after the admission to the PICU, the Pediatric Intensive Care Unit. The outcome, I think many of you can predict: chronic impairment, only lethargy. She had response to pain, rigor, posturing in the upper extremities, pinpoint pupils, minimally responsive to light, minimal tracking of the eyes. So this is a child who will never have a future. And the reason she will never have a future, to some extent, yes, inadequate access to medical care, no insurance, ED as your primary doctor visit, but she did see pediatricians, again, in an area where they didn't recognize tuberculosis or the risk for tuberculosis, didn't know how to treat it. Did ultimately get to where she needed to be, a pediatric intensive care unit, but by that time it was too late. I'm not passing judgment on anyone involved in this case. I don't know anyone involved in this case, but I wonder if a nice upper middle class Walnut Creek white family had a child with fussiness and fever that didn't respond, if that child would end up in the same circumstances, as opposed to a poor family with a history of drug use, kind of iffy parenting history. So the issues of poverty and social class and access to care and risk behaviors that we judge as a society absolutely impacted this child's chance for a future. So there is that interplay, once again, between the healthcare system and our social systems. All right, so that's enough grimness. Now, on to the positive. What's the role of tuberculosis programs in achieving health equity, right? Actually getting there. Equitable access to care, equitable outcomes for tuberculosis patients. Well, obviously, and I can't believe I forgot to put this on the next slide, but I did, the clinical care that you provide, many of you being medical directors, and those few TB clinics that are around, or those consultants who actually know TB, the fact that Curry Center and others teach how to treat TB, those are huge. So we're making inroads, although it's getting harder. There aren't very many TB clinics left. We're creating regional specialist networks, informal networks, et cetera. But finding ways to maintain that cadre of clinicians who know how to treat, to recognize it, to think about it. Let's start there, because that's usually where the first error occurs, is not thinking about it, to diagnose it appropriately and to treat it well. So that's one thing that the TB control community can really help to achieve, is that healthcare equity. But then it's what you do every single day in your dealing with clients. So that intensive case management, I will never forget my first 6 months as a TB control officer. I wandered around going, what is it I'm supposed to be doing? You know, I came from academic medicine and an ID fellowship, and I had been moonlighting in the TB clinic for a couple of years, so I knew that I had that clinical piece, beginning to have that clinical piece, but public health TB, God. Well, one of the things was meeting with the nurses and hearing about what they did, and one of the stories that always struck me was one of our most, strip all the kind of laden context, a crotchety woman. Like, she was really, both to absolutely everyone. She was completely equitable. She was hardcore, did not suffer fools. She was going to tell you exactly what you needed to do at any given moment. And she approached me and her patients in exactly the same way, which was appropriate. But she was, talking about a case that had been really difficult to keep that group that patient and actually a couple of members of his family in care. And she said, I finally figured out what he needed. I taught him how to use the bus system. And that struck me in a way that a lot of, sort of esoteric knowledge hadn't. Her willingness to literally get on the bus with this guy, show him how to use it, show his wife how to use it, which was culturally a really challenging thing, was huge. By the time that they finished therapy, he had gotten a job that he had to take a bus to. His wife was going to an ethnic market where she had not been able to get to before. That little thing that made access to services, so not just medical services, but to society, huge. Those little things that you do every single day, those of you who are public health nurses and others, are tremendously important to our clients, not just in getting them through their TB therapy, but so many of them, particularly those who are relatively isolated if they've been here for a while or new to the country, need those services to be well set up for the future. And then programmatically as well, we do addressing people's, that's the piece, addressing disparities. So the fact that you come every year, maybe twice a year, and you listen to Pennon and you look at graph after graph after graph, and you see where those lines are separate or the bars are higher. Sorry, Pennon. I love that stuff. Come on, I gave those talks. I gave those talks for years. Now I don't have to. I can just throw a few pictures up there. But it's really important, and the reason it's important is we live in a world of limited resources. It's not just our clients, but our programs have limited resources, and I'm here to tell you they are not going to increase. Okay? Let's just be clear. At CDPH, all of our planning scenarios are, at best, stable funding. And that's important because it means if you don't know where the disparities are, you can't target your programming. The same amount of money spread across 39 million people in the state of California has much less impact than that same dollar amount focused on specific communities where the problem is greatest. And that's about equity. That's not about equality. Equality is the 39 million people. Throw up a bulletin board across the state of California. It's going to cost you the same amount as going into a community, even a large immigrant community, and really educating people about tuberculosis so that when somebody in their community develops TB, they're the ones who bring that person to your attention so that they can get treatment. So using the data that we have on where the need is greatest is critical to getting the biggest bang for the buck in those limited bucks that we have. And then the focus on prevention. Every single person in the room knows that the more we can prevent, it's so much cheaper. It's just so much cheaper. And that is a hard sell, and I've yet to find the magic way of talking about it that makes it happen. And I think realize that most of the people who are making decisions about large sums of money are thinking about people who are already sick and need care. It's a hard thing to say, take some of that money and do this with it. Because I will tell you that you take 1 penny out of Medicaid, Medi-Cal in California, as an elected official, and you will be pilloried by everyone. Because the community in the United States only really understands the health care piece of it. They know they want that doctor to be there when they need the person. And so we're having an argument with the entire society when we try to talk about prevention. But it can be done, and we have done that, and you do that very well in tuberculosis. And there are lots of different strategies we don't have time to talk about because I think I'm running over my time. But anyway, ultimately, the most important thing that we can do to achieve health equity in terms of tuberculosis is the TB elimination plan. If we can carry this out, if we can find a way to actually get to elimination, and stay there. It's always about staying there. This is not just a United States problem. It's a problem around the world. And so hopefully if we can achieve it here, we can also have an impact in the rest of the world, at the very least by demonstrating to some fairly well-developed countries who have resurging tuberculosis that they too can do this. So you're already doing the work. You all understand, I hope, the issues. At least now you have some language. If you didn't before, most of you did. And mostly, it's just been incredibly honor. It's a great honor for me to get to talk to you, and I thank you for inviting me. And I'm staying for the rest of the day, so if you have questions or concerns, you're more than welcome to come talk to me. And I'm actually going to be doing podcasts with a few of you, so thank you in advance. I really appreciate that. I'm not sure about the agenda. Do we have time for questions or sure? We have a little bit of time for questions if anybody has any questions. There's a rush to the microphone. They're beating each other. Cool. Well, that just proves that you already knew everything I said, so we're good, right? Thank you very much. I really appreciate it.